All right, so a couple of points I didn't get to in my lecture, and hopefully we can get to those points with some of these interactive cases. I mean these cases to be a little fun. It's like having fun with really bad trauma and disease, which, you know, doesn't work necessarily, but let's find out how it goes. Okay, so let's start with this case. This is a real case. The indication is major blunt trauma status post-tracheostomy. So take a look. See if there's anything that bothers you. And I would suspect most of you won't be too concerned. Okay, got it? Let's move on. Okay, so first question, is this just X-ray normal or abnormal? So you got normal, you got abnormal. Is this a trick question? I'm not sure, and leave me alone. So go ahead and make your choice. I have no idea if this is going to work, by the way, but let's see. It's coming. It's coming. Now, yeah, you don't have to be a radiologist to know the answer here. So I'm really worried about some of these other groups. Okay, yes, of course it's abnormal. Why would I show you? Well, maybe it's not abnormal. Let's see. Let's talk about what it is and why it's abnormal. Maybe that's the point. All right, so abnormal. All right, now what I want to show you is something that you probably don't pay any attention to. The tip of this tracheostomy is 2.6 centimeters above the carina. The carina is here. The carina is this little edge where the two main stem bronchi come together. It's named for being a keel. Okay, that's what the carina is. So 2.6 centimeters. Okay, so given what I just showed you, I want you to speculate that this is an abnormal distance. What complication might you expect? Aspiration, airway occlusion, pulmonary embolism, tracheal arterial fistula, tracheal venous fistula. Okay, so you're thinking that this thing can now go another 2.6 centimeters down even further and occlude the airway. Good, that's great. It's wrong, but that's good thinking. Okay, so let me show you something that is scary. Okay, because what I'm going to show you is a tracheal arterial fistula. All right, now I'm going to go back in this patient. This patient was a motorcycle victim. Lots of fractures, just a lot of things. 35-year-old father of two. His initial hospitalization was at a smaller community-level hospital. He was intubated for about 19 hours. You can see that the tip of the ET tube is about the level of the tops of the sternoclavicular joints, very close to that. And look where the tube stops. It stops right at the base of the innominate artery. So the innominate artery normally comes up, goes anterior to the trachea, and then proceeds to divide into its major branches. Okay, but you really don't want a tube, a tracheostomy tube, sitting against the innominate artery. There's almost no literature that shows an endotracheal tube injuring the innominate artery. Now, there are other problems with balloon cuffs and traumatic tracheal intubation, but just sitting there usually isn't a problem. Now, in this particular patient, what happened was normally the tracheostomy tube is placed between the first and second or second and third tracheal rings. In this case, the tube was placed between the 8th and 9th tracheal rings, a distance of over 5 centimeters. Yes, this is a medical legal case which has been resolved. Okay, so what happened was the tip of the tracheostomy itself was right at the level of the innominate artery. So when the balloon is inflated, what you get is pressure on the back of the innominate artery. Okay, that's one possibility. The other possibility is the tube was angled and was slowly burying itself or burrowing into the innominate artery. Now, what I did out of pure interest was to measure the distance between the tip of a tracheostomy tube in patients in the ICU in my hospital to the carina. And this is the range of measurements. So here was 2.6. The average patient had about a 5.2 centimeter measurement, and the lowest one was 3.6 or 3.7. In other words, you got to pay attention to where the bottom of the tracheostomy tube is, that it can be too low. Most of you looked at this and you said, yeah, because that's what we do every day. We see these every day, and 99.9% of them are, yeah, okay. But this one was too low, and I know why it was too low, because the guy had a real bull neck, and it was probably very hard to feel the landmarks, and they let a medical student do it who was being supervised by a surgeon. So probably not an ideal situation. In any event, pay attention to the tip of the tracheostomy tube and how low it goes. This is standard tracheostomy. This wasn't particularly a long tube or something else abnormal about it. And they tell me this is the hole that was made in the trachea. I have some problems with this from a pathologic point of view. I'm just saying that there's no edema, there's no hemorrhage, and I don't know what happened here. So I'm a little suspicious about that, but that's what the pathologists swore to. So, okay. Number 2. 21-year-old man falls, has hypoxia, comes in, gets lots of tubes and lines. So just take it all in. Okay. Based on the chest radiograph, what question would you ask the trauma team? Does anyone want to go out for a beer after work? What's the bicarbonate level? Are the chest tubes in the pleural spaces? How many units of blood has this guy had? And are his neck veins distended? I'm going to make you clinicians for a moment. All right. Well, pretty good. The actual winner are the chest tubes in the pleural space, which is the right question, and I'll explain why that's the right question. Actually, the best answer is this one. Okay. It's not right, but it's the best answer. Okay. Okay, so what about the chest tubes? All right, well, let's go back for a second and look at this. All right, if there's a tension pneumothorax on the right side, and I hope you all agree that there's a tension pneumothorax, that things are pushed over, but mainly the diaphragm is pushed down, and the chest tubes are in the correct place, and let's assume that's happening, and let's assume that the correct circuit, that the air leak is not in the circuit, it's perfectly intact. Why is there still a pneumothorax or a tension pneumothorax? Why, if everything was done correctly, do we have that situation? Okay, so here's a CT, obviously, portion of a CT, a little magged up, and there's a finding on the CT. We're in the right lower lobe, 2 different axial projection, and then more of a sort of a coronal oblique, because I wanted to bring out the finding. Okay, you can see some contusions and lacerations, and this is actually, I'm in the bronchus, you're in the bronchus, and you're looking outside the bronchus, and you're seeing lung staring back at you. Okay, so diagnosis that you in your report would include all but the following: complete right-sided pneumothorax, right scapular fracture, left rib fractures, left lung contusions, traumatic aortic injury, and right lower lobe bronchus tear. Okay, so which one of those is not going to be in your dictation as a positive finding? Good. It would be great if we could diagnose traumatic aortic injury on a plain film. Some people think they can. They're usually called, those people are usually in jail or very poor. You can't do that, and I really wish you could, but no. So everything else is true. Okay, so what's happening here is you've got a big air leak. All right, so if you've got a big air leak from a bronchus, main bronchus, or a large bronchus, and in this case a lower lobe bronchus, air is going to leak out of that as fast as you suck it out of the pleural space. So what you have is a continuous circuit of air being pulled in a circle. Okay, until you close that big hole, you're not going to get anywhere with relieving the pneumothorax, even if it's a tension pneumothorax. So if that is the situation that you're dealing with, the problem is there's a hole in the lung, a big hole in the lung, a bronchopleural fistula, or a major airway injury that hasn't been identified. Okay, that's a real important point. Okay, and number 3, so we have this patient admitted. He's 53 years old. He's been assaulted. He's been a trauma center victim for 3 weeks. Okay, here's his initial chest radiograph in August 23rd. So decide what you think's going on here. Don't get fancy on me. Just tell me what, just think about what it probably is. So he had some chest tubes placed, then he had some pigtail catheters placed to evacuate as much fluid as they could. And here's one of the chest tubes, which is this guy right here. And there's another chest tube that's real hard to see down in the lower portion of the hemithorax. Both of them were placed, in the pleural space. Okay, a little epipleural hematoma. So he is now going to be discharged to a rehab center. So he has his pigtail trains removed. Nothing else is done. And so the next thing that you should do after you remove the drains is discharge the patient to rehab with a hearty, good luck, buddy. Double check that the patient still has insurance. Otherwise, he bounces back, and nobody likes that. Do a 1-hour follow-up chest radiograph. Do a 1-hour follow-up chest CT, or just put a larger chest tube in for insurance purposes. So what would you do? A lot of people are jumping in on this one. Right. Let's pull the tube and let's look at what happens. Does he get a pneumothorax again? Does he have some other complication? You should never remove a chest tube or anything like that and just send the patient off. But that did happen in this case. All right. The patient was at the rehab center for about 3 hours. Became diaphoretic and short of breath and looked really bad. And guess what? He bounces back to our center and has this readmission chest x-ray. Now they've treated him, obviously. You've seen he has another couple of chest tubes in. Okay, so now what do? You resign. Perfectly honorable. You call a code just in case things go poorly. You get a CT without IV contrast. You get a CT angiogram of the chest. You do a chest sonogram. Great. If you're going to go to CT and you want to find out what's going on in the chest, which is probably a huge hemothorax, you'd like to know maybe is the bleeding still occurring, so of course you want to do a CTA. Okay, so here's the CTA. And remember there were 2 chest tubes. One was about at this level, pigtails. One was about at this level and one was down here somewhere. And what's this? Blood. So this is active bleeding coming from the area of the pigtail catheter. Okay, so this is what he looked like when he left. Here's that catheter. Okay, so most likely diagnosis now. Patient was stabbed at the rehab facility. That's not so unlikely. Don't just dismiss that. He developed a sudden unexpected coagulopathy. He's had a delayed rupture of the internal mammary pseudoaneurysm that he's had for 3 weeks. He has iatrogenic intercostal artery injury, and a voodoo doll was impaled in his thorax. Okay, again, not completely dismissible. I got to see how many E's come up. A mysterious group of folks. Yeah, great, very good. Okay, so I've done this. Okay, if you do interventional procedures, you're going to do it. So you want to go under the rib or over the rib? over the rib, over the rainbow. You don't want to go under it because that's where the artery lives. So you want to just bounce off the rib and then slip over the top of the rib. If you go in the anterior chest, there is no room between the ribs. I learned this the hard way. I was asked to suck out a tiny little pneumothorax, and I said, well, I don't want to do it, but it was insisted I did. I put the catheter air, I sucked out the air. They said, leave the catheter in. I did. It was pulled later, then the patient bled to death because they could get no control over the intercostal branch that I hit when I went through that. So this is real iatrogenic disease, and that's what happened. This patient is still in the shock trauma center. Now we're 3 months out. And he's had ARDS, and he's been on ECMO. It's been a nightmare. So this is no small iatrogenic problem. So be aware that, again, when you pull a tube out, you need to, make sure. Now, unfortunately, we're not the clinical team. We could not have helped this situation as being radiologists. But still, just be aware that an iatrogenic problem like this with a rebleed certainly could occur. Okay, those are my cases.